Welcome to this episode of the Healthcare Bridge, where we explore the vital connections shaping our healthcare landscape. Hosted by Nathan Kaufman, Managing Director of Kaufman Strategic Advisors, the Healthcare Bridge is dedicated to improving healthcare delivery by strengthening the strategic and financial performance of healthcare providers. As part of the Common Bridge family, our focus is on fostering insightful, nonpartisan conversations that drive meaningful change in the healthcare industry. We invite you to join us as we build bridges toward a healthier future. The show is available on Substack, YouTube, and your favorite podcast platforms. Search for the Common Bridge and stay connected.
This is Nate Kaufman with the Healthcare Bridge. You can find us under the Common Bridge, which is Rich Helpy's podcast. Our purpose is to provide an insider's perspective on our crazy healthcare system. You know, there's lots of academics and policy wonks out there who talk about what we need to do to improve our healthcare system. My feeling is if you want to know what to do to improve the healthcare system, let's talk to people who actually deliver healthcare. So today, our guest is Dr. Rod Oskouian. Welcome, Rod.
Hi, Nate. How's it going? Thanks
Good.
for having me on.
My pleasure. And Rod is a world-renowned neurosurgeon practicing up in Seattle. Rod, why don't you give us a little background of your origin story and a little bit about your current practice?
Yeah, thanks. I appreciate you having me on, Nate. So I grew up in Seattle, and interestingly enough, I grew up at a time when technology was starting to take off. And the school I went to, all the kids' parents worked for Microsoft, except for mine. Mine, were classic immigrant story. Both my parents worked really hard. We grew up with nothing. We had like a one-bedroom apartment, and all the kids, computers were really popular. And I remember I scraped everything I had to get my first computer. But all the kids that I went to school with ended up going into tech. I was the only one that went to med school. And then I did my undergraduate work at the University of Washington. And then I went to UCLA for medical school. And then I did my residency in a really famous program that John Jane used to be the chairman of. Very academic, very traditional training. Like he wouldn't let you graduate unless you had 100 or more papers. You had to have like 95th percentile on your boards. And then he made sure that you went into academics. So if you went into private practice, you would be disowned from the family. And so I spent a year in New Zealand, in Auckland, and that was fascinating, Nate, because for me, it was the first time where, it's like when your mom and dad let you go out with the credit card. Where I got out of this, where you're kind of in a closed system. And in Virginia, University of Virginia, it was, very traditional academic, work 7 days a week. Everything was the same way that, it was very regimented in terms of it was a very classic American healthcare system, right? Where, it doesn't matter if you're 90 or 60 years old, everyone got the same treatment. And in New Zealand, it was my first experience where I was like, okay, they just have a different philosophy about surgeons, neurosurgery, tertiary care. So it was a great time in my life. And I spent a year there. And my wife, who's a pediatrician, took the year off. And we had a great year. We just had our first daughter, and she was about 1 year old. And then I wanted to, again, just because of my training and my background, I was only really looking at academic jobs. And so I was looking at UCLA or some jobs on the East Coast. And then I ended up at Swedish because I just knew a lot of the people at the time. And there was a lot of stuff going on in Seattle. And it was just when Swedish had decided to go into neurosurgery and they wanted to have a neuroscience institute. And I had to I remember my boss, that it was going to be an academic practice that I was going to have. So it was like he made me swear that I would, have fellows and that, I would continue the kind of UVA tradition, which is to publish and to have a fellowship, and continue to go to all the meetings and all the stuff that academic surgeons do, write grants and, write books and all this stuff. Like, he just kind of like really preaches. And I was really fortunate because when I came back to Seattle, I was able to reconnect with all my old friends, and there's so many cool things that were happening on the tech side that I've been able to get involved in it. Like, for example, we started the Seattle Science Foundation, which is now the largest online medical education platform in the world. I think last year we had like 23 million views. So, again, I've been in practice now for almost 18 years, and it's incredible to see how much things have changed, even from when I started, Nate.
Well, you anticipated my first question. You are in a practice with 4 other physicians.
That's correct.
And
right.
You're known as folks that do complex spine work, so you're a regional referral center. So let's start with, how has practice of neurosurgery changed over the last 20 years, both from the standpoint of clinical practice, because few people really get a chance to talk to neurosurgeons,
Right.
and also from administrative aspects.
So I would say that from like a day-to-day perspective, from my clinical responsibilities, I would say that because of what's happened, and I think this has happened nationally, is that the smaller hospitals and I would say the typical community practices that were here when I first started are no longer there. And so it's created, and I think this was done both, I think Obamacare kind of accelerated it, but, forcing, the private practices to have EMRs and, all these things where it just is so expensive on top of everything they were doing. It kind of forced a lot of them to, hang up the shingle, and they got acquired. And that's what happened to Swedish, right? We were kind of a standalone, not-for-profit, and then we basically got acquired by Providence. And so I would say my practice is now, I'd say I'm busier than I've ever been, and I would say we cover more and more hospitals. When I first started, we really only covered our downtown hospital, and that was it. Then we started covering all the Swedish ERs, because the private practice surgeons that were practicing in Swedish left. So then we went from covering 1 ER to covering 7 ERs to now where we cover all of Washington, in terms of, like when they need to transfer people, and then parts of Montana and Alaska, and then they call us from Idaho. So we cover kind of like the whammy states. So I would say my practice has become more of a tertiary regional center. So we get all the very complex patients. And then what I think from that standpoint, I think it's definitely something that I didn't expect. And then on the sort of, I'd say, the administrative or healthcare side of it, I think it's changed even more dramatically, in the sense that, when I first started, I had there was one administrator that I kind of worked with. And then as things have evolved, now it's so complex, there's such a matrix in terms of the organization. And I think for me, that's probably been the most challenging. We've had something like, I can't even count. I think we've had 5 or 6 CEOs, for like our health system, and then our other health system had, probably like 2 or 3. And that doesn't include all that, they kind of reorganize every few years in terms of, trying to figure out what's the best management model that they have. And I'd say when I look back at my residency, they didn't teach me any of this stuff. And it's interesting, Nate, and, you don't really understand the complexity of healthcare in the US until you actually start practicing. And then when you start practicing, you really realize you have no idea how decisions are made. So it's definitely evolved, and I think, when I look back on it, I would have never predicted that these two things would be kind of independent of each other.
So a question about your practice. One of the things you hear in the media is about spine surgery, and there's unnecessary spine surgery going on and all of that stuff, and that Medicare could save all kinds of money if, I don't know, that we did less spine surgery. What's your perspective on the need for spine surgery, the authorization for spine surgery, and the overuse of spine surgery?
I think that's an excellent question. In fact, it's interesting because most of the data they use, and in fact, recently just another article came out where they only look at Medicare data, and that's kind of tricky, and they had this paper come out in JAMA. I don't know if you saw it, but they called, they put spine surgery, pacemakers, TAVRs, all these things that are kind of, they call it low value care. Okay. So, and then what's always difficult, and just being an academic person, when you really slice and dice the data, they're using Medicare data, they're using billing data, they're using outcomes in, if you think about Medicare patients, these are the sickest of the sickest. And then, for example, they go, okay, well, TAVRs and pacemakers and fusions, they're costly and they don't work, right? That's the message that they sent out. And if you look at that population, if that's what their message is, I think if you really peel the layers of the onion away, I think part of what's gone on is that the cost of healthcare has gone up, but where's the cost really? I think it's, if you look, when I look at our stuff, physician reimbursement's gone down. Hospital reimbursements gone up over the years. And then if you look at the number of administrators, that has skyrocketed, right? So the overhead has gone up, and then pharmaceutical companies continue to, do well. Insurance companies do great. Device companies are doing fine. But then, we're the bad guys, or bad, we're the people that are causing, like all the healthcare costs, especially in spine. It's really, I think it's hard to, when you have this data continue to come out, it's really disheartening, because I think they're sending the wrong message. And actually, when you look, for example, like when you look at these TAVR patients, the ones that have critical aortic stenosis where they get a stent, they actually do, when you look at their overall outcomes and how they actually do remarkably well. And so I just think, yes, these devices are expensive, but in the grand scheme of the economics of this is, when they have an agenda, and their agenda is do less procedures, I think you can kind of spin the data in such a way to make it look like that.
Do you find a lot of denials and having to do peer-to-peer reviews for your patients?
All the time. I mean, all the insurance companies are guilty of this, and the policies, and this is part of the problem, is each one has their own policy. For example, in spine fusion, this is one we battle all the time, where they go, okay, well, they'll say that this procedure is experimental. and they'll create their own policy, and then they'll say, well, we have our own, policy, and then it has to go through our medical director and our review process, and they use, and I've seen this, and I think you've probably seen this in the news. Well, that nobody actually reviews it. It gets denied as a first step because they don't think you'll appeal it. So then, and it's interesting. In fact, I just was involved in a recent one where, finally got to the physician, and then, the physician's like, okay, it's approved, but it took like 6 months to get through all this stuff. And I'm really fortunate because, I have a layer, I've got, a nurse, I have my fellows, I've got a team. But can you imagine if I didn't have any of that stuff? Most doctors, this patient would have never ended up getting surgery.
Well, was the patient in pain?
No, this was actually, it was very interesting. It was a nurse who had had multiple surgeries, and then she had fractured the rods in her spine. And so she developed this thing called camptocormia, where she was like literally bent over 90 degrees. And so she needed to have a pretty extensive reconstruction. And then just based on the previous surgeries and everything they had, it was just very difficult to get her surgery approved. And again, I mean, this is typical, where, she was from Eastern Washington, and this, she had good insurance, but the insurance company knew that this was going to be like $200,000-$300,000, and they did everything they could to, it was just like every single thing I had to appeal, and we finally actually got her on the schedule, but it was really frustrating.
Wow. So you mentioned earlier that you are employed by a healthcare system. There's those out there that feel that there's a conspiracy on the part of health systems to control the doctors and to eliminate independent practice and all that. You kind of mentioned it. I find that most or many neurosurgeons are now employed by health systems. Is it possible to be an independent practice in neurosurgery today?
I don't think it's impossible. I think you can do it. I think if you do, a lot of my colleagues, like in New York and LA, there's certain markets you can do it. I think you could do it in Seattle, San Francisco. You would have to, unfortunately, go the fee-for-service model, where you set your, say, this is my cost for my surgical fees. But, you wouldn't necessarily be able to do Medicare. You certainly couldn't do Medicaid or, some of the other governmental programs. And you basically, I think, would have to have a pretty thin staff. But I mean, I still have a lot of friends who, and you'd have to do all that out of network stuff, which a lot of doctors like myself, I agree with you. I don't think there's some conspiracy by the larger health systems. I just think that the way that it's set up, I think that all the mergers that were done, I don't think the hospital, running a hospital is not like a roll-up business where you go in and you go, okay, well, now we have 20 hospitals, we can, and this is, I think, what's happened in a lot of these larger health systems. They go, well, now instead of having like, there's some efficiency of scale, but then you can't, for example, let's say if you have a pharmaceutical or pharmacy, they go, okay, we're going to shut all the pharmacies down. We'll have one pharmacy, right? We're going to have all the IT be in one place. We're going to have HR is going to be in one location. And I think with healthcare, you can certainly do that with some things, but I think it's hard to do command center for everything, just because healthcare is so complicated.
Yeah, I mean, I sent you the article I just wrote in HFMA on that exact subject, that there are too many silos and nobody looking at the overall picture. So one of the things that I say is, health systems employing physicians is a great idea, except they don't know how to do it, and physicians make lousy employees. From your perspective, if you could give advice to a health system about how to work with employed physicians better, in a time when finances are constrained or very difficult, what would be your suggestion?
I think that's a great question, Nate, because I think I've been on both sides where, and again, when I think most health systems, especially the larger ones, I think there's no question that there's all these silos that develop. And I think when I look at, for example, like in my practice, we have, there's so many things that physicians have to do from a regulatory standpoint, insurance, documentation, getting all of our, like certification for our licenses. And I mean, there's so many things that we have to do, credentialing, that like, that's one aspect of, of being a physician. But I think there's another part to it. And I think this is where my comment going back to, they never taught any of this stuff in med school, is that it's a business, right? So I think most doctors, like when we go to med school, we're not taught about EBITDA. We're not taught about, Medicare. We're not taught about private insurance. We're not taught, but now all these things are, we have, and this is the other thing that's happened is, these terms get kind of thrown around, and not a lot of systems, and I think ours is the same. They have like the business to what we do, and the docs usually aren't involved in that. I mean, you'd be shocked. It would be shocking for me to tell you this, but they just aren't. We're not in. We're not at the table when they're making financial decisions or big decisions. For example, what EMR do they want to use? What imaging system? Now, there might be docs like in management that are involved in it, but there's the doctors that are on the ground. I feel like there's a disconnect between what decisions are actually made, and there's a disconnect between the physicians that are on, like, dealing with the emergency room, all these I mean, and I think they're big decisions. Like, for example, what AI system are they going to use to implement from a enterprise level, right? And so they'll get a physician who's really smart and hasn't practiced in 15 years. And they go, oh yeah, well, this is a great system. We're going to use this AI system. But then you go, oh wow, it doesn't integrate with, our EMR, or it doesn't, for example, for us, you go, okay, there's no, you can't code on it. You can't use it for your op notes. You can't use it for billing. Well, there goes 90% of like what I would use AI for.
So I always find that you have to be, number one, radically transparent with your doctors. You also have to find the right leaders, because you can't have every doctor in the room on every decision. And you've been the leader of this complex spine program up in Seattle. Any thoughts on physician leadership and the do's and don'ts?
That's Nate. That's something I think I've learned a lot along the way, and I've learned a lot from working with people like you. Honestly, because like I said, it's not a skill set that we're taught. In fact, when you look at training and neurosurgery training, it's the most elite. It's like the Navy SEALs of residency, right? I've been programmed. It's like you want to kill your competition. That's the way neurosurgery works. The only reason you get through is because all these other people have died off in the process. That's how that training is. So for me, in terms of like leadership, we never got any classes, and we never, like even the attendings that I worked with, God bless them all, but there was no, it was like it was their way or the highway. I mean, that's just how the training is, and I've learned along the way, and I'm continuing to learn. I mean, it's one of these things. I think leadership is something that in residency in medicine is not really taught well. I think you kind of learn as you go along the process. And I think, and again, like for me, it's really interesting because it's so important, as you said, you want to be able to have an impact. You want to help the system. You want to try to be involved in decisions that are going to affect, like the spine program, or how they do the marketing. And it's something I think I'm not very good at, but I'm learning.
Okay. So I'm going to do a HIPAA violation here and mention the fact that I am aware that you had a significant skiing accident several years ago.
That's
You were
correct.
you had surgery. You were in the hospital for some time and rehab. What did you learn being a patient about that you didn't know before?
So that actually, Nate, that was one of those experiences. I think it changed my life forever. As a neurosurgeon, I've never like stared death. I remember it was a bad ski accident, and I had basically had missed a turn, and I went off the edge of a cliff, and I really thought I was going to die. And thank God there was about 1.5 feet of snow that came the night before, and I had a really bad landing, and I broke my leg, and I think that whole experience really changed my perspective. I think when you're a patient and you see, and this happened in Big Sky, Montana, which again, there's a nice emergency room there. I got great care, but you see how complex the health system is. And I thought I had great insurance, right? And so I landed in the ER, and then everything that was happening, was a learning experience for me. And even I remember, the fracture of my leg was so bad, and I developed compartment syndrome, and then I had to go to a regional trauma center, which is Harborview, and they did a phenomenal job, but all these things, like all that stuff was quote unquote out of network, so again, I mean, it ended up getting resolved, and but you realize, okay, yeah, your insurance, what's considered in network, is it if it's not, life threatening, you have to get some sort of pre-authorization, things like that. And I had been discharged home, but then I had, the information had been relayed from the emergency room to the surgeon, and then they had scheduled my surgery. But there was kind of, so you realize, you go, wow, our health system, and here I'm a neurosurgeon, is so complicated. And then I think the thing that I learned the most, Nate, from all this is it's very, very interesting, because this was a different health system. And is that, and I think this is part of the problem that has gone on in the US. And I can't believe it took me this long to figure this out. But if you look at most sort of businesses, or, let's say if you go, okay, you have a company, right? Your customer is, who your customer is, and this is what you're doing. In healthcare, it's kind of interesting, and this is where it kind of dawned on me, is that most health systems, I think, regardless of where you are, if you ask them to say, okay, what's the business that you're in and who's your customer, they will tell you it's the patients, right? They'll say, well, we're here to serve, the community, and we do cancer care, or we do orthopedic care. That's what we do. When I think it's actually the opposite. I think it should be, the health system should say, our customers are our doctors, right? And so the focus should be, okay, we're going to do as much as we can to make sure our doctors are happy, they're productive, they have all the tools they need, whether it's from technology or, clinics, and we're going to try to minimize, make, like, our goal is to make our doctors as happy as possible. And we're going to recruit the best doctors and pay them really well. And then they're going to be very productive. And in return, they will take care of, like, our patients, And I wish Medicare had that same concept. And I remember my old chairman, John Jane, God bless him, he was so smart. He said, Rod, when I started neurosurgery back in the 50s, we got $5,000, $6,000 for a laminectomy. Now we get $500. And he said, what they should do is, if you do a laminectomy, they should pay you $50,000 now. If you do the economics, right, over that period of time. And what that does, and I remember him saying this, and he's like, it would, and I'm not saying people are doing unnecessary surgery, but it would make it so physicians are very selective, and you would do the surgery at the right time and right thing. But I think instead, with Medicare and all the insurance companies, they think if they devalue something, quote unquote, make it a low value, that their costs will go down. And I'm not sure I don't know if that pencils out,
So when you had your accident, I know you kind of looked around where to go because it was a very complicated case. Did you shop based on price, or did you shop based on the fact that you're an insider and you know who the best of the best is?
Honestly, it's being an insider. And that's where, again, I think, it's, even with my insurance and everything, they kept telling me that if I went to this doctor, it would be out of network, right? And so I had to actually fight for myself to get that. Finally, I was like, look, yes, these other surgeons can do it, but this guy does, 5, or, this surgeon does 400 or 500 of these surgeries a year. And this is all they do. This is the group I want to go to. And it's kind of like my practice, where you want to go somewhere where they do lots of these surgeries. And so usually that's a place that there's fellows, they run multiple rooms, they're operating 6-7 days a week, and the surgeons they're just very skilled at what they do. And in medicine, you want that, right? You don't want someone doing one of these a month.
So how do you find out? What's your advice to patients? I mean, I know, because I'm an insider, I can make a few phone calls and figure out who's the guy or gal that I need to refer to for a particular thing. But the average patient, there's academics saying, just give the average person the money you would give the insurance companies and let them go buy their own healthcare. How would they know where to go?
They wouldn't, Nate. And what's interesting, in fact, if you do a Google review on me, right? There's probably and I operate on 400 or 500 patients a year. It's like trying to figure out what restaurant to go to. The reviews are always the people that are unhappy, and they'll write, you'll have 20 negative reviews, even in a great restaurant, so these, and the way these search engines work, for example, Google, these reviews don't ever go down. They're there forever. And so that's not a great way. And so I think unless you're an insider, I actually don't know. I mean, that's a great question, because it's really complicated.
One last question, because we're running low on time, but I'm just curious, like, when we hear about outcomes and how they measure outcomes, it's infection rates and it's readmissions and it's mortality. Is anybody really measuring the outcome of spine surgeries now?
So yes and no. So we do lots of what's called PROs, patient-reported outcomes, and it's very difficult because, for example, you'll have a workman's comp patient who you do a discectomy and they're disabled for life. They need handicap parking and everything they fill out is negative. Everything's bad, right? And then you have, the 90-year-old who had a odontoid fracture who bakes you an apple pie and is doing great. So I think it's really difficult and it's very subjective. I think the future, and this is where I think tech is going to help, I think outcomes should be, they'll measure how many steps do you take, what's your blood pressure, are you doing your PT? I mean, all these things now they can track, right? Like I see you have an iPhone watch, Apple Watch. Yeah, and an Oura ring. So, people, and this is what another interesting thing, they're paranoid about their privacy, but I'm like, look, if you have an iPhone, you don't have privacy. They already have all your data. And so when I show people, that they're being tracked, they freak out. I'm like, well, what do how do you think these steps are, they're being recorded and they're biometrics, they call it. So I think it's going to shift towards biometrics. And I think it'll help the doctors, it'll help the patients. But using now, for example, and this is what's done a lot, Nate, and you've seen this, where they use Medicare billing data, this is very dangerous. And they do this for these low-value procedures. And then they go and they use these things called patient safety indicators. And the hospital, you would not believe this, but the hospital will try to code everything, right? Because they get more reimbursement. So the hospitals will say, oh, this patient needed a blood transfusion, this. They have high blood pressure, diabetes, right? So they're medically complex, so they get this modifier, and so they get a little bit extra money. Well, what does that do to your outcomes? Now, your outcomes look terrible, because you have the sickest, and that's what's happened to us here. Like, if you look at my practice and go, gosh, this is a disaster. Their PSIs are high, they have all these things, and length of stay is this. But then when you look at it, well, yeah, we're getting all the sickest patients, and so it's a subset of the general population. So I think it's hard to measure outcomes right now. But I think in the future, I think tech's going to help.
So I'll tell you this, if I need spine surgery, Rod, just save me a seat. I'll be up there and expect you to do it because you have a great program. And so our guest today, Dr. Rod Oskouian, I really appreciate your candor and honesty about what you think about healthcare. Healthcare is extremely complex, and a lot of it doesn't make sense, as you've heard. There are a lot of opinions out there about what should be done, but one thing you should remember is if you need healthcare, seek the guidance of an insider because your life may depend on it. Thank you, Dr. Oskouian. This is Nate Kaufman with the Healthcare Bridge.
Thank you for joining us on this episode of the Healthcare Bridge. We hope you gained valuable insights into how strategic and financial analysis can transform healthcare delivery. Remember, building stronger connections in our healthcare system is a collective effort, and we're honored to be part of that journey with you. Be sure to subscribe and stay tuned for more conversations that aim to bridge gaps and create a healthier future for all. You can find all your Healthcare Bridge episodes at The Common Bridge on Substack, YouTube, and your favorite podcast platform.